Welcome to KJR SummaryCast, audio summaries of peer-reviewed articles published in the Korean Journal of Radiology. Designed to enhance reader convenience and the overall KJR experience, SummaryCast provides conversational audio overviews for time-constrained listeners and mobile-friendly learning. This recording was created using a combination of AI tools with oversight from the KJR editorial team or the article's authors, including necessary edits and corrections. For the most accurate and complete information, we encourage you to also read the original published article.
Welcome to SummaryCast.
Today we're exploring a paper from the Korean Journal of Radiology, published in Volume 27, Issue 2, 2026. It's titled Prospective Evaluation of Irreversible Electroporation with Clustered Electrodes as a Novel Palliative Approach for Locally Advanced Pancreatic Cancer.
That's a dense title. Let's unpack it. We're talking about locally advanced pancreatic cancer, or LAPC. This stage 3 disease, where the tumor is confined to the pancreas and surrounding structures, but has encased major blood vessels.
Exactly. This vascular involvement, often of the superior mesenteric artery or celiac axis, is what makes it unresectable. So the goal shifts from cure to palliation, controlling the tumor, managing symptoms, and extending survival.
And irreversible electroporation, or IRE, is one of the tools for that local control. Remind us of the mechanism.
It's a really clever, non-thermal ablation technique. Think of it less like burning or freezing the tumor, and more like using precisely controlled electricity to make the cell membranes permanently leaky.
So it applies very short, high-voltage electrical pulses.
Right. These pulses create irreversible nanopores in the cancer cell membranes, disrupting their homeostasis and triggering apoptosis, or programmed cell death.
And the key advantage here is what it doesn't damage.
Precisely. Unlike thermal methods that cause indiscriminate coagulation necrosis, IRE tends to preserve the delicate scaffolding of connective tissue. This means the extracellular matrix of blood vessels and bile ducts remains intact, which is a huge advantage when you're working in the anatomically crowded neighborhood of the pancreas.
But the paper suggests the standard method of performing IRE isn't without its challenges.
It's extremely technically demanding. The standard approach uses multiple individual monopolar electrodes that the operator has to insert one by one around and into the tumor.
And getting the geometry of that placement right is everything.
It's the whole game. For the electric field to be effective, those needles have to be perfectly parallel and maintained at a very specific distance, usually between 1.5 and 2 centimeters.
Which sounds almost impossible to do consistently in an organ that's deep, mobile, and surrounded by critical structures.
You nailed it. You're trying to thread multiple needles into a moving target. If the electrodes converge, the current density gets too high and you can cause unintended thermal injury. If they diverge, the field is too weak and you get incomplete ablation, leaving viable tumor cells behind.
So, at best, it's a very long procedure that requires immense skill. At worst, it's ineffective or unsafe.
Which brings us to the core innovation of this study, the clustered electrodes. This is an engineering solution to a clinical problem.
Instead of freehanding it with multiple individual needles, this is a single device with the electrodes pre-configured.
Exactly. The system uses dual, triple, or even quadruple electrodes that are fixed in a specific geometric arrangement, like an equilateral triangle for the triple. This locks in the spacing and parallelism before you even start.
So it takes a major variable off the table. The operator just has to place one device correctly, not coordinate 3 or 4.
The hope is that this makes the procedure faster, more reproducible, and safer by ensuring a more homogeneous and predictable electric field. This study is the first prospective look at whether that hope holds up in patients with LAPC.
Let's get into the study design. What did they do?
This was a single-center prospective cohort study at Severance Hospital in Korea. They enrolled 13 patients with unresectable LAPC and treated them with this clustered electrode IRE system between September 2022 and September 2024.
13 patients is a small cohort, but being prospective is a strength. What did this group look like? I'm looking at Table 1.
The median age was 60, and as you'd expect, all 13 had vascular invasion, which was the defining feature. Tumors were mostly in the pancreatic body or tail, and the median size was 2.4 centimeters.
And I see all of them had received prior chemotherapy, mostly FOLFIRINOX. That's a heavy-duty regimen, so these are patients who have already been through significant systemic treatment.
That's a critical point, and it seems the chemo had some effect. The median CA19-9 tumor marker at diagnosis was over 350, but by the time of the IRE procedure, it was down to a median of 94.6.
That tells you these are tumors that were at least somewhat responsive to chemotherapy before the local treatment was even considered. So, first question, feasibility. Did the new device work as intended?
Yes, 100% technical success. In all 13 patients, they were able to place the clustered electrodes correctly and deliver the full planned course of electrical pulses. Most procedures, 11 of them, were done intraoperatively, with 2 performed percutaneously.
Let's dig into the procedure details in Table 2. What does delivering the pulses actually entail?
It's a very controlled process. They delivered a protocol of 90 pulses per treatment cycle, with each pulse lasting between 70 and 90 microseconds. The output voltage was high, typically 2,500 volts, to create the necessary field strength.
And it's synchronized with the cardiac cycle to avoid arrhythmia.
That's right, it's all electrocardiographically synchronized. After the first 90 pulses, they would check the current. If it remained stable, they would deliver a second set of 90 pulses to ensure a thorough ablation.
So it's a feasible and highly standardized procedure. Now for the crucial part, safety. What did the complication profile look like?
The top line number is good, 0 60-day mortality, no procedure-related deaths.
That's the most important safety signal. But what about morbidity?
Here, there were issues. Major complications defined as grade 3 occurred in 2 of the 13 patients, which is a rate of 15.4%.
And both were GI bleeding. That's a red flag.
It is. The first patient's tumor abutted the stomach, and they developed bleeding 10 days post-procedure from the right gastroepiploic artery. The second presented with hematochezia at 2 weeks.
Were they able to control the bleeding?
Yes, in both cases, the bleeding was successfully managed with transcatheter embolization, and the patients recovered fully. The authors note that this type of delayed bleeding is a known risk of any pancreatic IRE, often from vascular injury along the needle track that can lead to a pseudoaneurysm, which then erodes into the bowel.
It underscores how fine the margins are in this area. What about minor complications?
Much more frequent. 10 patients, or about 77%, had minor issues. The most common was abdominal pain, followed by things like mild pancreatitis, dyspepsia, and nausea. All of these were managed conservatively.
Okay, so a safety profile that seems acceptable for a palliative procedure in a high-risk population. But the risk of major bleeding is real and requires a team ready to manage it. Now let's talk about efficacy. Did the treatment work?
The oncologic outcomes are really the headline here. At a median follow-up of 24.5 months, the median overall survival from the time of the IRE procedure was 20.1 months.
20.1 months. Let's put that in context. How does that compare to other treatments for LAPC?
It compares very favorably. The paper's discussion provides the benchmarks. For modern chemotherapy regimens like FOLFIRINOX, median overall survival from the start of treatment is typically 10 to 23 months. For historical IRE series with monopolar electrodes, it's often in the 10 to 14-month range.
So 20.1 months is definitely at the high end of, or even above what you'd expect from other modalities. What about progression-free survival?
Also strong. The median PFS was 14.5 months. For comparison, PFS with chemo or SBRT is often in the 7 to 12-month range.
The numbers are definitely encouraging, but this is where we have to be careful. In a small, non-randomized study, strong results beg the question, why? Is it really because the clustered electrode is a superior ablation device?
That's the million-dollar question, and the authors are very cautious here. They propose that yes, the clustered electrode could lead to a more homogeneous electric field and a more effective ablation. That's a plausible contributor.
But the alternative hypothesis is that this was simply a very well-selected group of patients.
Precisely, and the data supports that. As we noted, over 92% had a very good performance status. Their tumors were relatively small with a median of 2.4 centimeters, and the median interval of 14 months from diagnosis to IRE is quite long.
That long interval is a big signal. It suggests these patients had more indolent disease biology, the kind that was controlled by chemotherapy for over a year before they even needed local therapy.
And that brings us to the biggest confounding factor, the role of chemotherapy. It wasn't just an adjunct, it was central to their treatment. 100% of patients got chemo before IRE and 85% got it after.
How does that compare to prior IRE studies?
It's a stark contrast. The paper cites the big PanFire studies. In PanFire 1, about 50% of patients did not get chemotherapy before IRE. In PanFire 2, it was about a third.
So we can't say that IRE with clustered electrodes is better than chemotherapy. We can only say that adding it to a robust chemotherapy regimen in well-selected patients yielded these encouraging results.
Exactly. This study showcases a combined modality strategy, not just a device. Interestingly, 2 patients who did not continue systemic therapy right after IRE remained stable for 6 and 17 months, respectively.
That is a neat detail. It might hint at a very durable local control provided by the IRE in those cases, strong enough to allow for a chemo holiday.
It's a tantalizing signal, but again, from a cohort of only 13 patients, it's just an observation.
So let's land this. What are the practical takeaways and future directions?
The primary takeaway is that this refined technology, the clustered electrode, appears to successfully address a major technical limitation of traditional IRE. It makes the procedure more straightforward and potentially more reliable.
It's an incremental but important engineering improvement, and the results suggest that when this improved local therapy is integrated into a modern, chemo-heavy treatment paradigm for well-selected LAPC patients, the outcomes can be very good.
But this is not a practice-changing paper on its own. It's hypothesis-generating. The authors are clear that these findings are exploratory and need validation.
What would that validation look like? What's the next logical study?
The ideal next step would be a larger, multi-center randomized controlled trial. You'd take a cohort of LAPC patients who are stable after induction chemotherapy and randomize them. One arm would continue with systemic therapy alone, and the other would get systemic therapy plus clustered electrode IRE.
That's the only way to truly isolate the additive survival benefit of the local ablation. It would also be interesting to see more data on the percutaneous approach.
I agree. Only 2 patients in this study were treated percutaneously, but the authors mentioned their broader institutional experience suggests it has real advantages, like more precise electrode placement under real-time imaging and avoiding a laparotomy.
So, in conclusion, this study presents a strong proof of concept. It's a well-designed, prospective look at a clever technological refinement that makes a difficult procedure easier and more reliable. And when used in the right context, the results are certainly promising.
Well said. It's not a revolution, but it's a very meaningful evolution of a palliative tool for a disease where every incremental gain matters.
An encouraging development in a challenging field.
That concludes this episode of SummaryCast.
Thank you for joining us.